Hello, I'm Dr. Milica Vukicevic, a Harvey scholar coming from the MGB campus in Boston. I'm delighted to be here with one of the luminary academic leaders of our time, Professor Marc Pfeffer, who recently reflected on the DIGIT-HF trial in the New England Journal of Medicine. Professor Pfeffer, few therapies in heart failure have had as long and as complicated a history as cardiac glycosides. From the DIGIT trial to near abandonment and now renewed interest after DIGIT-HF. Today, I'd like to revisit what we learned and what we forgot and what comes next. DIGIT-HF trial was an international double-blind placebo-controlled trial in patients with chronic heart failure who had a left ventricle ejection fraction of 40% or less and NYHA functional class of 3 or 4, or left ventricle ejection fraction of 30% or less and NYHA functional class of 2 in 1:1 ratio to receive digoxin or placebo in addition to GDMT. The primary outcome was a composite of death from any cause or hospital admission for worsening heart failure, whichever occurred first. This trial, done in Germany, Serbia, and Austria, showed that treatment with digoxin led to a lower combined risk of death from any cause or hospital admission for the study population. But let's go back a little bit. When the DIGIT trial reported 30 years ago, what did you believe was its most important message for clinicians, and why was the community less enthused by the very signals which are now associated with acceptance of newer drugs?
Well, thank you, Melissa. And you're right, this is a very long history. Actually, it's over 200 years of this history. But we were so used to digitalis. We were so used to using it. It had all the surrogates. It did what you wanted to. You could measure ejection fractions improved. On the cath table, you could show cardiac outputs improved, wedge pressure down. So we were all very excited about it, and it was the foundation therapy. If you look at all the prior studies, it's on top of DIG and diuretics. So foundation therapy, we all believed in it. And then new studies came out, and new studies were all saying, show me mortality difference. So 30 years ago, a heart failure trial was not built on 16 endpoints. It was built on who's alive and who's not. And that's how we have beta blockers, that's ACE inhibitors, who's alive, who's not. Put that standard to digoxin, and we were waiting. It's going to be wonderful. And it wasn't. It was neutral. Now, neutral is a terrible term for a clinical trial. It's not all in a neutral. So what do? It didn't make people live longer. So then it gets put away. From great use to now put away. But it's at the same time we have beta blockers and we have other therapies coming in. So this new recurrence, you'll tell me more about. You mentioned the trial. It was on a different cardiac glycoside, but it opens the door all over again. So let's talk about that.
Well, how do you interpret later concerns about harm in women in light of modern reanalysis and now DIGIT-HF?
So Monday morning quarterbacking, it's a neutral study. Does that mean everybody, no one benefited? Does it mean some group was harmed? So the first thing to look at is today's standard, we combine endpoints, mortality and hospitalization for heart failure. By that standard, the DIG trial was very positive. Mm-hmm. And then an analysis of women, subgroup, large numbers though, relative to today's studies, showed potential harm, an interaction for death. Is that true? We'll never know unless the study's done again. So when it comes to safety, you don't need the same bar as you do for efficacy. So you can raise a safety concern with a subgroup. You can raise a safety concern with small numbers. it doesn't prove effectiveness, but safety, that should get your attention. The other part of safety was the dosing and the serum levels. We used to use serum levels to try to bring it up. Let me give this person more. Now, in the current study and in the ongoing study, it's just the opposite. Use the serum levels to keep people in a safe range. So we know a lot more about it now, and maybe use of digitalis is going to be even safer by using lower doses. And the other thing I'll add that we didn't have 30 years ago, defibrillators. If the risk is arrhythmia, what about the person who has an ICD? So I think the situation, we're now ready to reevaluate DIG using lower doses and the right patient population.
Very important question. If DIG showed reduced hospitalization, why did routine use of digoxin steadily disappear? Was the problem the drug, or how we dosed and monitored it? Or did beta blockers, MRAs, and later on ARNIs crowd digoxin out? Or was the evidence misinterpreted?
All of the above. All of the above. But it went on the back burner, and I think it shouldn't have. But we can think all we want. We're going to have a study pretty soon. But when the standards were mortality, it went on the back burner. But when the inotropes showed reduced survival, the positive inotropes, everyone was saying, oh, my patient needs this. And people who work with advanced heart failure use it to get through the night, but you can't use it long term. So I used to say, a neutral finding for mortality in something that's making someone feel better and keeping them out of the hospital is a positive. So it is neutral for death, and it is positive for hospitalization. We should be using it. But then, as you mentioned, we've got other tools to use, and the real question is, with today's other therapies, will DIG, and you can talk about the cardiac glycoside of your choice, will it improve outcome? And that requires an outcome test.
As you mentioned, in DIGIT-HF, hospitalizations again drove the benefit. Is this confirmation of the DIG biology or coincidence?
Well, the mechanism is wonderful. It's an inotropic agent. There's more calcium for the sarcoplasmic reticulum to pick up and improve contractile state, which no one talks about anymore, but that is the fundamental problem with reduced ejection fraction heart failure. So it's there. Now we just need to prove it's safe, which you just said we did. And that study with a different agent, digitoxin, didn't show harm, showed benefit on the composite. It's not an agent we have here in this country. If you have it and you're used to it, I think you have to get used to it. So I'm not worried about the renal function because we know how to dose. We now know how to dose. Impaired renal function, so impaired maybe you don't use, but a little impairment, measure the serum levels, make sure it's not too high. The liver metabolism for digitoxin is of interest, but I think a physician should get used to one. Learn how to use one of the two. And in this country, it's digoxin.
When talking about those differences, digitoxin and digoxin differ in renal clearance, half-life, and variability. How meaningful are these differences clinically? Is it scientifically fair to let DIGIT-HF inform modern digoxin use?
It's not a matter of fairness. It's a matter of when you practice medicine, use the best available evidence you have. We're never going to have a study the two agents head to head, nor should we. There's more things to study. But I think a person has to get familiar with how do you use this, what happens when you dose in people with kidney disease. So I think the similarities of mechanism is very important, and I would extrapolate. That's all you're going to be able to do.
Decision AJF is nearing completion and directly tests digoxin. Should the field wait?
The field can wait, but you, as a doctor taking care of somebody tonight, can't.
Yeah.
So you can use your best judgment. I think we've shown these drugs are, if used judiciously, are not going to hurt people if you're monitoring. It's not the kind of thing you just give and walk away. So if you have the person who's back and forth in the hospital, reduced ejection fraction, you've tried everything else, you're ready. You have enough. But let's hold our breath and wait for it's only months away, and it's using digoxin. It too is not going to be 6,000 patients. It too will not be definitive. But when we put all the information together, what we just had from digoxin, what we're about to get from digoxin, I think the story will play out, and I'm really enthused looking for it. I don't expect to see a mortality difference. Mm-hmm. You know, there were over 2,000 people that died in the DIG study, and that's probably more than will be enrolled in these newest mm-hmm. studies. So it won't be definitive there, but again, if we show benefit on top of the therapies we like to use, no harm for mortality in women, and that would be, we won't have enough numbers to show that, but we'll look for trends. And relating to serum levels, I think that will wake us up again about another way to help human beings with heart failure and depressed ejection fraction.
Professor Pfeffer, thank you very much for pointing the most important facts. I would ask you one more question. Where is heart failure therapeutics heading?
Well, we're very lucky. We now know that you could be surprised. You could be surprised in the wrong direction. You could be surprised in the right direction. The SGLT2 inhibitors, boy, no one would have. They were not developed for heart failure. So people thinking about where in the laboratory do you look for agents? This had nothing to do with heart failure, but what it had was large numbers of people at risk, and there it was. In the diabetes populations, fewer people died, fewer people developed heart failure, and then the heart failure audience, your audience, took it from the diabetologist and said, I want to try it, and tried it, and it has nothing to do with diabetes. Benefit, benefit, benefit. It's wonderful. So what's tomorrow's benefit going to be? Is it going to be somebody in the lab saying better contractile state, better this? Or is it just going to be, let's get exposure and take a look? But it does mean that you can keep moving the needle. If you think about what the mortality in heart failure was at the time of the DIG study, and you think about the mortality now, it's amazing. And then you think about advanced heart failure. I'm in the room of people who do advanced heart failure. The machines, the assist devices, even transplants being improved. So I think this is an optimistic time for heart failure, from prevention to the tip of the iceberg, the super sick people.
For sure it is, and I would like to use the opportunity to thank you so much for being part of this interview, and also for reminding us that progress in heart failure is not only about discovering new molecules, but also about learning to use evidence old and new with discipline. This is Heart Failure Minutes with Dr. Milica Vukicevic signing off. Until next time.